Welcome to St. Boniface Hospital in Winnipeg, Manitoba. Founded in 1871 by the Sisters of Charity of Montreal, it is the oldest hospital in Western Canada. We are a tertiary healthcare facility with over 554 beds and is Winnipeg's second largest hospital. Each year, over 6,000 infants are born at St. Boniface Hospital. As per hospital protocol, the majority of our infants are placed in Kangaroo Care following delivery with his or her mother. This includes both vaginal and C-section deliveries. What is Kangaroo Care? Definition of Kangaroo Care is holding of a diaper-clad infant bare chest to bare chest, ventral service to ventral service by mother, father, or other caregiver. The practice of Kangaroo Care dates back to the late 1960s for full-term infants and the late 1970s for preterm infants. Benefits of Kangaroo Care for infants: physiologic stability, temperature, blood pressure regulation, heart rate, and respiratory stability. Brain, cognitive, and motor development. Decrease in cortisol. Improved attachment and bonding. Improved rates and duration of breastfeeding. Decreased response to pain experiences. Heel pokes. Benefits of Kangaroo Care for parents: improved rates and duration of breastfeeding. Decreased risk of postpartum depression, mom and dad. Attachment and bonding. Increases confidence in caring for infant. Out of the 6,000 infants, over 500 of them will be admitted to the NICU. We are a Level 3 neonatal intensive care unit made up of 30 beds, 2 isolation beds, and 4 observation beds. On average, we run with 13 nurses per shift. Reasons for admission to the neonatal intensive care unit will vary for each infant, and each case may come with many challenges. One of those challenges to our most vulnerable patients is enabling these patients and their parents to participate in Kangaroo Care. At this present time, we encourage skin-to-skin for all infants except those that are actively cooling, nor have we done it with infants who have chest tubes. For our extreme premature infants, or those infants whose medical condition is fragile, our present protocol is to discuss the topic of Kangaroo Care in our morning rounds so that all disciplines involved can participate in the decision and planning.
My name is Diane Schultz. I'm a staff nurse in the NICU at St. Boniface Hospital.
And my name is Kimberly Hamlin. I am also a staff nurse at St. Boniface Hospital.
So we attended a national neonatal conference in Phoenix about 10 years ago and had the privilege of listening to Dr. Susie Ludington talk about the science behind Kangaroo Care and the many benefits of it. We also have had her come to Winnipeg and present her information here so we could share that information with our staff. When we came back with that knowledge, we wanted to increase the Kangaroo Care that we were doing in our unit for our patients. And then what we found is that we were lacking in the transfer process information.
So when we returned back from Phoenix, whether it was a simple transfer or one with a more medically complex patient, we found that there was inconsistencies. We did not have the information to support it within our own guideline, nor could we find it. So hence, working with our staff, our families, and the individual patients, we were able to update our nursing guideline and created a standard protocol.
The creation of this video is the end product of all the work that our staff have done to safely transfer our infants out to Kangaroo Care.
We have one for the nurse transfer and parent transfer. When deciding on the kind of transfer to use, there are a few things to consider. Is this the first time for Kangaroo Care? The present physical condition of the infant. For an example, is the baby ventilated or non-ventilated? The ability of the parent to participate in the transfer. For example, is the mom able to mobilize safely in and out of the chair while holding the infant? Is she able to bend over to pick up the infant from the bed? Sometimes, when it is a complicated transfer due to equipment and physical condition of both the infant and mother, the nurse transfer may be the best choice to try, especially when it is the first time holding. The goal should always be to transfer the infant safely and without creating undue stress, so that the infant and family receive the full benefits of Kangaroo Care. This video will demonstrate both transfers, and then follow with a transfer in full live sequence. For the purpose of this video, a mannequin doll was used to demonstrate the transfers with both staff and parent volunteers. The live sequence from start to finish was with an infant and their parent. Following a planned discussion with your care team, identify each person's role and responsibility during the transfer. Ensure that a physician is within your unit should an unplanned extubation occur with the medically complex patients. Discuss with parents ahead of time when Kangaroo Care will be done. Explain what the parent will see and the role of each team member. Allow for them to share any concerns or ask questions before you begin. Infants can be assessed and placed into transfer position with previous assessments before the actual Kangaroo Care transfer to the parent. This will minimize disruption and decrease the amount of handling of the medically complex infant. Let us begin with the nurse transfer. Have the parent remove his or her shirt. No bras should be worn. Remember, this is Kangaroo Care. Put on a gown or jacket with an opening to the front. Position the kangaroo chair at the side of the ventilator. At this time, the infant's head should be positioned away or to the opposite direction of the ventilator while in the isolette or open bed. If the IV pumps are not on the same side of the ventilator before you begin, place your pumps on a pole or ensure they are portable. With assistance from your team member, the IV pole will be slowly moved following the infant while he or she is in the parent's arms. Have your parent sit in the chair. Ensure their backs are right to the back of the chair. Once the parent is comfortably sitting in the chair, the nurse will place one hand under the infant's body and head, while the second hand is gently placed on the top of the infant's body and head to create a sandwich position of holding. The respiratory therapist will be responsible for the ventilator tubing, while the second team member, for an example, a second nurse, will monitor all IV lines, pumps, and monitoring cables. Gently lift the infant straight up and slowly transfer the infant laterally onto the parent's chest without moving his or her hands. Once the infant is on the parent's chest, instruct the parent to place one hand on the infant's back and the other hand on the infant's head. The transfer nurse will leave one hand on the parent's hands to ensure positioning for both infant and parent. The transfer nurse will then slide their bottom hand down from underneath the infant's chest and head and place it on top of their other hand. Once the parent is secure with holding the infant, gently angle the chair 30 degrees off midline. The respiratory therapist will maintain the ventilator tubing during the transfer and positioning of the infant until the final resting position is reached, and then the tubing will be secured. The second nurse or team member will assist with re-establishing monitoring cables and securing IV tubing. Additional pillows, blankets may be placed for support and security at this time. The pillows and blankets under the parent's arms will reduce strain on their shoulders and back while holding their infants for prolonged periods of time. Monitoring of the infant and parent should continue throughout the entire process. Remember to document your assessment of the infant in Kangaroo Care. This is a therapy not only for the infants but also for the parent. For the medically complex infants, the transfer team should debrief to discuss how the transfer went. What could be improved for this infant? Did the parent have any concerns? What went well? To return the infant to the isolette or open bed, simply repeat the previous steps in the reverse order. The second transfer is the parent transfer, most commonly suggested to be used with more stable infants and is a graduation step from the nurse transfer once parents have become more confident in handling their infants. The beginning of the transfer entails much of the same organization of your team members as the nurse transfer. Parents are dressed in a gown or jacket open to the front. Remember, no bra. The chair is set up beside the infant's ventilator. If needed, IV pumps may be secured to a pole or if not mobile for easier transfer. The infant is wearing only a diaper. Ensure your infant's head is to the desired position prior to the transfer. Secure all IV lines and monitoring cables. Have the parent stand in front of the infant. The bedside nurse should be at the parent's side. The bedside nurse will direct the actual transfer, but reinforce at any time. Any one of the team members, including the parent, may say stop to ensure safety. The respiratory therapist will be on the side of the ventilator, while a second team member is positioned by the IV poles and lines. Equipment will vary from hospital to hospital, but if able, position the open bed or isolette at the parent's waist level. Bending at the waist, have the parent lean over their infant, chest to chest. The parent will place their hands under either the infant or under the blanket the infant is lying on. One hand under the head while the second one is under the diaper area. Remember to have the parent bend to the baby and not the baby to the parent. Stand up straight and pause. Safety check for all team members to ensure no IV lines are caught and ventilator tubing is not pulling. With assistance, direct the parent to pivot to the front of the chair. Staff will be holding all of the monitor cables, IV lines, and ventilator tubing. Have the parent sit down in the chair slowly. Once they are seated and their back is firmly against the back of the chair, only then angle the chair back to 30 degrees off midline. Lock the chair. Secure ventilator tubing once final position is reached. While parents maintain their hands on the infant, cover infant with blanket. Ensure all monitor cables are in place and IV lines and pumps are secured. Continual monitoring of infant and parent is done throughout the process. Additional blankets and pillows may be used for support. To return the infant to his or her isolette or open bed, repeat the same steps in reverse. Remember to discuss your transfer with your team. hope this video will encourage healthcare providers to participate in Kangaroo Care for our most vulnerable infants and their families. Taking time to plan a safe transfer is the key to success. Our video and commitment to Kangaroo Care is dedicated to all our patients and families who teach us every day why touch is needed. And a special thank you to our fellow staff who have practiced the skill of transfers.